Hi, this is Dr. Gregg Stone from the Icahn School of Medicine and Mount Sinai Hospital in New York City. We performed a sham-controlled randomized trial called the RELIEVE-HF study to see if creating a small interatrial shunt connecting the right and the left atrium would decrease left atrial pressure and improve prognosis in patients with heart failure. And we previously reported the results from the RELIEVE-HF trial, which showed overall benefits in patients with heart failure and reduced ejection fraction, but actually detriment or harm in patients with heart failure and preserved ejection fraction. So the question was, do these results apply to all patients, or could we actually determine predictors of outcomes in the HFrEF and HFpEF strata? So we could try to individualize care, to predict which patients are more likely to benefit with a shunt and which patients may not benefit or actually be harmed with an interatrial shunt. Well, it was a pretty high-risk population. These patients had mostly New York Heart Association Class III heart failure and were quite symptomatic despite being on maximally tolerated doses of all Class I guideline-directed medical therapies. And they had depressed Kansas City cardiomyopathy scores, decreased 6-minute walk distances, and they had a high rate of events during 2-year follow-up. And we looked at a composite clinical event rate of all-cause death, heart failure, heart transplant or LVAD implantation, all heart failure hospitalizations, and all outpatient worsening heart failure events. And again, there were a lot of events in this trial, particularly in the patients with heart failure and reduced ejection fraction. So what we did was we looked at the univariable and then the multivariable baseline predictors of all events. This was a recurrent events analysis. And from that, we created a risk score for events within the 4 separate strata. That is HFrEF patients treated with a control, that is just medical therapy, HFpEF patients HFrEF patients treated with a shunt, HFpEF patients treated with control, and HFpEF patients treated with a shunt. Then once we had those individual risk scores, we could apply each patient's individual baseline characteristics to see whether they would do better with a shunt or with just medical therapy treatment. So what we found was first looking at HFrEF, that is the left ventricular ejection fraction less than or equal to 40%. There were 4 independent predictors of 2-year adverse outcomes in patients who were treated with medical therapy alone. And then we looked at the patients who were treated with a shunt alone. And we also found that there were 4 predictors, but they were totally different predictors. And this was from a very large covariate set of 37 baseline clinical, laboratory, transthoracic echocardiographic, and hemodynamic predictors from right heart catheterization. So 4 predictors that were independent for HFrEF outcomes treated with control or placebo, and 4 treated with shunt. When we then put them into the risk model, we actually saw that approximately 2/3 of the shunt-treated patients, 67.2%, benefited. 2/3 of the HFrEF patients benefited by treatment with a shunt, whereas about 1/3 or 32.8% were the same or worsened with a shunt. So based on their, again, individual risk factors, which were different for shunt versus control, you could actually predict which patient might do better with the shunt versus with the control. We then did the exact same type of analysis in patients with heart failure and preserved ejection fraction. That is HFpEF, left ventricular ejection fraction greater than 40%. And we found that there were 4 multivariable independent predictors of adverse outcomes in control-treated patients with HFpEF for 2-year adverse events. And we found that there were 6 multivariable independent predictors of adverse outcomes after shunt treatment. And once again, the outcomes, the predictors were totally different. So putting in the atrial shunt changes the structure and functioning of the heart. So you're trying to accommodate increased blood flow from the left to the right side of the heart. And the risk predictors of outcomes are different before and after you do that. And so when we looked then at each individual patient characteristic, we saw that 79% of the patients actually did similar or were worsened with a shunt who had HFpEF, while 21% of the patients were improved with a shunt with HFpEF. So this was all very interesting because the main results were that on a group population mean, it seems like the group markedly benefited in HFrEF and the group markedly was worsened with a shunt with HFpEF. But now when you look at individual risk factors, you could find that in both of those strata, there were some patients that were benefited and some patients that did not benefit. Particularly with HFrEF, we could identify 2/3 of the specific patients that benefited. And even in HFpEF, in which overall there was harm with a shunt, we still could find 21% of the patients who, at least in this modeling exercise, were more likely to benefit. Well, I think this really was the surprise. The fact that there was no overlap whatsoever in the risk factors before and after the shunt was kind of surprising. I mean, this small little tiny shunt, with a QPQS or right to left flow ratio of approximately 1.25 to 1 would lead to such marked changes that it changes the entire predictors of response. And that allowed us to do this modeling exercise and identify individual patients who really might benefit or be harmed. So this all was a very successful exercise and the results were quite surprising. The risk models were generated from modest numbers of patients and events. And while the models were good, they weren't perfect. So there's still certainly some uncertainty in the risk prediction. So we need larger validation studies, and there will be future studies that are going on with shunts in HFrEF and HFpEF that should look to reproduce these results. In addition, all of the events were treated equally in the prediction model. Most of the events were, heart failure, hospitalizations, and outpatient worsening heart failure events. But a substantial minority were death, but the population size wasn't large enough to just model mortality. So once we get lots more shunt-treated patients and other studies, we could potentially pool all of these studies to make a comprehensive model among a broader risk population of patients, and also then model mortality separately in addition to heart failure events.